Hello everyone. So today I'm back with a new video. That is, the topic is reduced fetal movements. And we are all aware that this is the most common symptom a pregnant mother comes to the antenatal OPD too. So each institution has a separate protocol for dealing this complaint. But what does the evidence say is what that matters. So today let's understand what is the importance of fetal movements and what is the implication of reduced fetal movements in our day-to-day clinical practice. So my today's agenda is introduction to normal fetal movements, the methods which we have to use, and to explain the mother the importance of perception of fetal movements, and an approach to a patient with a symptom called reduced fetal movements, and final tips away and takeaway messages. So, what is the importance of normal fetal movements? So, as we all know, there's something called as quickening. So, quickening is the perception of fetal movements for the first time during pregnancy. So, usually in a primigravida, it is seen around 18 to 20 weeks of gestation, and in a multigravida, it is around 2 weeks early. So, why is it early in a multigravida? Because mainly the mother would have been experienced the moments before, so she will be aware of what kind of moments is actually the fetal moments. And the second important reason is the maternal abdominal wall, the tone also decreases in a multigravida. So for this, the perception is felt much more easier than a primary with a taut abdominal wall. So once she perceives quickening, then she has to perceive her regular fetal movements. And this is one of the most important analysis to see whether the fetus is good or not. That is mainly to see whether the fetus well-being is normal or is it abnormal. So this is one of the easiest way where we can depict the well-being of the fetus. So that is why perception of fetal movements by the mother is very much important. And usually in a high risk pregnancy, when there are any maternal risk factors or any history of previous obstetric risk factors or any fetal risk factors, we tell the mother or we educate the mother to count her baby movements as early as 28 weeks of gestation. But then in a normal pregnancy, it is not of that importance. So in a normal woman with a or a low risk woman, fetal movements must be perceived if she has history of any reduced fetal movements. Otherwise, we need not ask her to maintain a chart or to maintain a record of a daily fetal movements. So coming to the normal fetal movements. So we all know that the fetal movements are perceived by the mother as early as 20 weeks of gestation. But actually the fetus starts moving by 7 weeks of gestation. So this earlier fetal movements can be appreciated on an ultrasound. But these movements become more coordinated and complex once the somatic nervous system starts maturing, and these movements are perceived by the mother as early as 18 to 20 weeks of gestation. So what are the types of fetal movements which we usually encounter? So there are four types of normal fetal movements, that is kicking, roll, squish and flutter. So these are the four types of movements which are actually described. But on an ultrasound, there are different kinds of movements like startles, hiccups, or the gross body movement of the entire body of the fetus, the extremities which are moving, and the clenching of the feet and the opening of the hands. So all these are different kinds of movements which can be appreciated on an ultrasound. But these fetal movements mature around 36 weeks of gestation. And we can tell that the fetal movements goes on increasing around 32 weeks of gestation. But after 32 weeks, the fetal movements slightly decrease because the fetus goes into a common presentation, and also the liquor also comparatively gets reduced. So that is why at term, that is during the after 36 weeks, the maternal perception is slightly reduced, but it will be in a normal range. Next, coming to, there is something called as fetal behavioral states. So this was described before, as early in 90s, that the fetus exists in utero in four behavioral states, that is 1F, 2F, 3F and 4F. So 1F is a quiescent state, so where the fetus is sleeping. 2F is something where the fetus has vigorous activity and rapid eye movements are also present. 3F is the rapid or continuous eye movement is present, but the fetus will not have any activity. And 4, it will have both vigorous activity and eye movements and gross body movements. So usually 75% of the time, the fetus spends its time in 1F and 2F states. And also the sleep cycle of the fetus will vary between 20 to 80 minutes of period. So that is why on CTG, if we are not able to recognize the acceleration, which is just the counterpart of fetal movements, we need not worry because the fetus might be asleep. So we can wait for around 90 minutes, and still if there are no acceleration, then it becomes important. So that is why once the accelerations are not present, we need not get worried. It could be a normal sleep pattern of the fetus which is causing the absence of accelerations due to the absence of fetal movements. So we can stimulate the maternal abdomen, or we can do some vibroacoustic stimulation. So all these we can do to awaken the fetus and then measure a NST to see if there are any presence of fetal accelerations. And also we can allow the mother to press the click to see if there are any movements in the strip of NST. So this is the importance of fetal behavioral states. Next, as I already mentioned, the ultrasound characteristics can be present as early as 7 to 12 weeks of gestation, where the baby is moving and it is visualized on a scan. And next important thing is the assessment of fetal well-being. This is assessed and it is the most inexpensive and it is the most subjective method where a mother will record the fetal movements throughout the day. So this assessment is very important for us to analyze whether she has perceived a good number of times she has perceived the fetal movements or not. So this helps us to understand whether the fetal movements are normal or reduced. So how do we assess the movements on a daily basis? So uh, there are so many methods to assess the fetal movements, but the most important ones are something called as a Sadovsky method. So this Sadovsky and colleagues introduced this method as early as 1973, and they told the mother should record the fetal movement in left lateral position or a semi-recumbent position postprandial, that is after food, once in the morning, once in the afternoon and once in the night. So at least for 1 hour. So these 3 hours into 4 will give the number of moments in 12 hours period. So if the moments is less than 10 in 6 hours, then it definitely requires a evaluation. So this is nothing but a Sadovsky method. And one of the interpretation or one of the modification of Sadovsky is something called as a daily fetal movement count, that is the DFMC, which also we recommend in the postprandial state for 1 hour immediately after breakfast, lunch and dinner, and in these 3 hours the fetus should have moved at least for 10 times. So if the mother has not perceived this number of movements, then it is definitely a indication for further evaluation. And the last method is called as a Pearson's method or a Cardiff count of 10. So this is nothing but the mother has to start perceiving the fetal movements at some point of time, like for about say about 9 o'clock in the morning. So she starts counting the fetal movements. So once she perceives 10 movements, we can stop. So when it is abnormal, if she does not perceive any fetal movements in 12 hours, or if she perceives less than 10 movements in 12 hours on 2 consecutive days, then also it is abnormal. So this is something called as a Cardiff count of 10 or Pearson's method. So these are the different kinds of methods which are used to explain to the mother the assessment of daily fetal movement. So this we can do, and we can ask the mother if it is normal or not. So then we will have to know some facts. So usually it takes only about 18 to 20 minutes for a mother to experience 10 movements. So this is a fact that we have to know. We might think, okay, in how many hours she might perceive 10 moments, but on an average, the range is 18 to 20 moments. The mother will perceive around 10 moments, and usually the range of moments is around 15 to 45 in a period of 1 hour. So usually 15 to 45, around 31 moments per hour, the mother usually perceives in a normal state. But if there is any fetal insufficiency or if there is any problem, then the movements might reduce. But this is the most common thing that we have to know, that the normal range of movements is around 31 per hour for a woman. Okay. So next thing is, reduced fetal movements actually important, but that we have to know. So if 10 women come with reduced fetal movements, in seven of the women, it is an uncomplicated case. We need not worry. That is 7% of the times the reduced fetal movements is not anything severe. So it is something that the mother has not concentrated or we have not documented well. So 70% of the time it's an uncomplicated thing, but around 30% definitely it's an indication, and it is a method for further evaluation of fetal well-being. And also we have to know, if a mother has reduced fetal movements, 55% of the time, if there is a stillbirth, it will be associated with the history of reduction of fetal movements. That is why we have to never ignore this symptom, telling this is all normal. If she has come with reduced perception, we have to definitely take the relevant history, do clinical examination, and evaluate and manage her. So that is what we are interested today. So, approach to a patient with reduced fetal movement. So, whenever a mother comes with reduced fetal movements, we have to take a proper history. So, when was the last movement she perceived, and what is the time interval between the perception of fetal movement and presently reporting to the hospital? And you have to also take any history of previous history of reduced fetal movement. So if she tells, some 1 week back I had similar complaint, so that is definitely a significant thing, because repeated episodes of reduced fetal movements is definitely pathological. So that is also taken into consideration. And after taking a detailed history regarding the reduced fetal movements, we have to also know some of the risk factors which are associated with this. So some of the maternal risk factors like diabetes, hypertension, primiparity, and usually obesity. The mother has history of smoking. The mother is taking any sedative drugs like benzodiazepines or alcohol or methadone, or if there is any anterior placenta, or if the baby has any fetal growth restriction, or if there is presence of any congenital malformations or any neuromuscular disorders. So all these are very important. And also the previous obstetric history also we have to include. Any previous history of stillbirth, any previous history of reduced fetal movements, any previous history of preeclampsia. So the past obstetric history, the present maternal risk factors, and any fetal risk factors has to be taken into consideration. So, firstly, we have to know what are the different factors which are influencing the woman's perception. So, I already mentioned, if there is any evidence of anterior placenta, any maternal risk factors, any sedatives the mother is using, or obesity or smoking. So, all these are very important if she comes with reduction of fetal movements. And then we have to ask for the subjective maternal perception. So, you have to ask the mother to lie down in the left lateral position or in the semi-recumbent position and count for 2 hours. In these 2 hours, if she is not perceiving at least 10 moments, then we have to further evaluate her. So at this point of time, if she is perceiving good amount number of times, that is more than 10 moments, then we can reassure her and we can discharge her from the health facility. But if the in this in this 2 hours time, if she is still not perceiving at least 10 moments, it needs for further evaluation. Next, is this important for all pregnant women? Definitely. Risk versus benefit ratio, we can ask the woman to count her fetal movements, but this is very important in high risk pregnancies. So mothers who have any present obstetric risk factors or any maternal risk factors or any fetal risk factors, this is of paramount importance. But in a low risk pregnancy, we can ask her to count the fetal movements if she has any history of reduced fetal movements, or for the sake of just for our satisfaction and the mother's satisfaction for knowing the fetal well-being, we can ask her to calculate after 32 weeks of gestation. But for a high-risk pregnancy, definitely we have to counsel the woman to calculate at 28 weeks of gestation. So from 28, she has to count the number of fetal moments in one day. And then this requires an optimal management. As I told you, we have to take a detailed history, do the examination, clinical examination, and do the investigations like CTG or BPP or USG. So now we have to know whether we have to do a CTG or a BPP or a USG. So which method of antepartum fetal surveillance we have to do if the mother comes with reduced fetal movements. For this, there is a beautiful chart and an algorithm which is being given in GTG number 57, that is reduced fetal movements, which is an RCOG guideline. So they tell that when a mother comes with reduced fetal movements after the 28 weeks of gestation, we have to take a detailed clinical history of the risk factors for stillbirth and fetal growth restriction. So I told you all the maternal risk factors and fetal risk factors has to be taken into consideration. If the history does not confirm reduced fetal movements, then we have to just auscultate for the fetal FHR, and if it is normal, we can do a routine antenatal assessment, and we have to give advice on further episodes of reduction of fetal movement. She has to approach to the health facility, and we can ask her to count for 2 hours. So if the count is more than 10 minutes, 10 counts in 2 hours, then it is definitely reassuring and we can send her home. But if she does not feel at least 10 moments in this 2 hours, we have to ask her to contact the healthcare facility. So this is when the history does not confirm or when she is not aware on how many moments she has perceived in the last 24 hours. Next, if the history confirms reduction of fetal movements, then we have to immediately auscultate for FHR with a handheld Doppler. So if FHR is absent, then we must include the suspicion of IUFT, that is intrauterine fetal death, and we have to send her for an emergency ultrasound to exclude any intrauterine fetal death. If there is IUFT, we have to manage as per the protocol. But if FHR is present, then it must be accompanied by doing a CTG to exclude imminent fetal compromise. So the three things we have to rule out. We have to exclude if there is any fetal compromise, if there is any fetal death, or if there is any risk factors which are associated with stillbirth or FGR. So these things we have to exclude if the woman comes with reduced fetal movements. So if the CTG is normal, then we can continue the assessment for FGR or stillbirth by doing an ultrasound. So if an ultrasound is completely normal, you can discharge. If the ultrasound is abnormal, if there is any evidence of FGR or oligohydramnios or Doppler changes, we have to manage accordingly. But if there is normal heart pattern on an CTG and there are no associated risk factors, we can reassure the woman and we can discharge her, and we have to ask her that she has to keep a strict DFMC chart with her, and if there is any situation where there are less than 10 moments, she has to immediately approach to the healthcare facility. But if the CTG is suspicious or pathological, then we have to definitely do the further evaluation and manage as per the protocol. So that is why the reduction of fetal movements is very much important in our clinical practice. So what all we discussed? We discussed the normal well-being of the fetus, what are normal fetal movements, the types, and then we also discussed the methods of perception like Sadowski, DFMC, Pearson's, that is Cardiff count of 10, all these methods, and there are other methods like clap which are not much practiced. So once if we have confirmed the history, we have to rule out the risk factors which are causing any IUFT or stillbirth. So then we can evaluate by auscultating the FHR by a handheld Doppler, and if the FHR is absent, we have to definitely rule out IUFT by doing an emergency ultrasound. But if FHR is present, then we can do a CTG. If it is normal, then we can explain the mother and we can allow her for a strict DFMC and discharge. If it is suspicious or pathological, it has to be accompanied by doing a scan for BPP and Doppler. So this is how we approach for movement with complaints of reduction of fetal movements. So these are my references. The main important reference is the GTG number 57, where they've clearly mentioned how to approach a woman with reduced fetal movements. And also, if the fact is that if the woman has history of reduced fetal movements and the CTG is normal, the chances of stillbirth is as less than 1.9%. But if there is reduced fetal movements and we do a CTG, and if it is non-reassuring, if it is either suspicious or pathological, the chances of stillbirth is around 26%. That is why we have to be very careful in requiring a need for a CTG or a BPP or a scan for fetal Doppler or ultrasound. So that is why it is not mandatory to do everything in all patients. We have to see and do it like a stepwise evaluation. So that is how we will land up in diagnosing the early FGR or if there is any imminent fetal distress, and we can manage accordingly. So I hope this video helped you and you will definitely not get a doubt to approach a patient for reduced fetal movement. So this algorithm is always helpful and you can keep it in hand to follow this and approach a patient. Thank you. Happy learning.